Hello, welcome everyone, and thank you for joining me virtually for this skin cancer talk. My name is Alison MacKay, and I'm a physician assistant at West Sound Dermatology in Paulsbo. And I'm here to talk to you today about the most common skin cancers, what to expect as a patient with our most common treatments, and just generally make you feel a little bit more comfortable. So again, objectives today: identifying the most common forms of precancerous and cancerous skin lesions. To discuss treatment options for these lesions, I want to make sure that everyone knows that these are by far not a comprehensive list. These are simply the most common treatment modalities that I use in my clinic to treat these, and I think they're generally the most commonly used in general, at least in our clinic with our doctors and PAs and nurse practitioners. So in any case, my whole point today of today's talk is to make a skin cancer patient feel more confident about what to expect with your diagnosis and the therapy that is going to be provided. So some skin cancer facts and statistics. 1 in 5 Americans will develop skin cancer by the age of 70, and then more than 2 people die of skin cancer in the U.S. every hour. I'm sure multiple people watching this presentation right now qualify here. Having 5 or more sunburns in your lifetime doubles your risk for melanoma. But the good news is, when detected early, the 5-year survival rate for melanoma is 99%. About 90% of non-melanoma skin cancers are associated with exposure to the sun, to UV radiation. Basal cell carcinoma is the most common form. An estimated of 4.3 million cases of basal cells are diagnosed in the U.S. every year. Squamous cell carcinoma is the second most common form of skin cancer. More than 1 million cases of squamous cell are diagnosed in the U.S. every year. It's important to know that organ transplant patients are approximately 100 times more likely than the general public to develop a squamous cell carcinoma in particular. Regular daily use of an SPF 15 or higher sunscreen reduces the risk of developing squamous cell carcinoma by about 40%. So biggest skin cancer risk factors: indoor tanning and tanning beds, sunburns, especially in your youth and early 20s, skin type. So this isn't universal, but generally the lighter the skin color, the higher the risk. However, a darker skinned person can actually absolutely get both a sunburn and a skin cancer. Genetics, history of atypical moles, or again, as I discussed a minute ago, organ transplant history severely increases your risk factors. So probably one of the most common lesions, period, that I see in the office are the actinic keratoses, also known as the AK, precancers, sunspots. They are precursors to the skin cancer squamous cell carcinoma. And generally, you'll have multiple in a sun-exposed area. They're very common on the backs of the hands, the face, the chest, the legs. So how do we treat actinic keratoses? The most common form of treatment, and still probably considered the gold standard by most dermatologists, is cryotherapy or liquid nitrogen. This actually burns by freezing and creates an injury on the skin right in the area of the actinic keratosis, so that when the body resolves the injury, it takes the AK with it. So this is done in the office. It's a literal spray that's sprayed directly onto the sunspot. It burns and stings when it's being sprayed, but it's tolerable. You don't want to do it all day, but it's tolerable. That stinging will last generally until you get to the car, and then within the next day or two, the lesions that are treated will become blistery, crusty, scabby, and essentially look worse before they look better. Depending on what area of the body that's been treated, it will completely heal, most often within 1 to 2 weeks. So one of the main reasons that people kind of like this therapy is that it's very easy, it's very fast, you get it done right there in the office, and when you leave the office, you're finished. You don't really have to think about anything again besides just healing. There are topical prescriptions that can be used to treat an entire field, we call it. So for example, in this picture, the field being treated is the face. The reason we may use topical therapy is a patient will generally have multiple precancerous lesions, and we want to actually unearth the ones that haven't shown up yet. So the beauty of topical prescription therapy is that you will also get to treat the subclinical lesions, we call them. So on this lady who looks really excited to be having this treatment done, she probably came in with multiple spots on the sides of her cheeks there that you can see, and maybe a few on the forehead. I doubt that she had that significant redness on her face. That usually is a result of this treatment, which again will only target precancerous cells and do what I call light them up, which is essentially make them crusty and scabby. And then they heal up, and the skin is actually particularly smooth and nice afterwards. It's kind of hard to convince a patient when they're in the middle of this treatment that their skin really is going to feel dramatically better when it's over. But almost universally, every patient tells me when they're done, oh, wow, it really was not very nice to do the treatment, but my skin feels great at this point. This treatment usually takes anywhere from 1 to 3 weeks of applying the cream and having the redness, and then a couple of weeks recovery after that. So it's not always first line because it's just not feasible for some people to look crusty and scabby for maybe a month or longer. So, but we do retain it as an option because it's an excellent way to treat, again, an entire field. Blue U is another very, very common option to treat an entire field. So this is a treatment in which the patient's brought into the clinic, and usually a nurse or medical assistant will apply a chemical called Levulon to the field being treated. Again, I chose a face picture here. So the face is the field that this gentleman is having treated. We apply the Levulon chemical, which you can't see, and you essentially marinate in it for about an hour, sometimes up to 2 hours in a special location before you are then put under this light that emits a blue color and is U-shaped. And the U-shape is to get around the entire area. So for example, when we want to treat the face, we want to also get the ears. If we were treating the scalp, we might want to get the top of the ears with the scalp. And this sort of engulfs that whole area. So the light will only target the Levulon in areas of precancerous cells. So again, this will always light up new areas as well as treating the spots that you could see and feel prior to starting therapy. There's 2 things about this therapy that the patient really needs to consider. The first is this is a tough treatment. You sit under this light for 18 minutes and it does burn and sting in all the areas that are precancerous. So we do everything we can to try to make that more comfortable. Usually there's an assistant in with the patient the entire time. We have spray bottles that mist water on the areas and just keep it cool, and that's soothing during the 18 minutes of treatment. We have fans that kind of reduce that stinging sensation, but once it's done, the biggest deal is for 48 hours after treatment, you are exquisitely sun sensitive. So you need to be aware that you need to stay completely away from sun. That means when you're driving a car, the windshield could actually, you could get enough sun through the windshield to get a severe burn. When you're at home, you want to kind of stay away from windows and significant light because of the burn potential. Once that 48 hours is over, though, your skin returns to normal, and, well, to the degree that you don't have to stay out of the sun. But then you have the crusty, scabby areas that have also developed from the treatment, which also heal within about 1 to 2 weeks. You also need to know, if you choose this treatment modality, it is very common to have to do 2 treatments, sometimes 3, to eradicate all the lesions. The first treatment usually gets the majority of them, and then second treatment, we hope, wipes out the rest. Or sometimes we'll combine Blue U with liquid nitrogen. So say a patient had 30 lesions on the face. They do the Blue U and it's successfully treated 25. If they have 5 left, you might elect to freeze or use cryotherapy for that last 5. Again, quick and easy. Patient's done, doesn't have to sit through the Blue U again. Chemical peels are also an option for AKs. They're definitely very, very infrequently done in my office. They can be difficult to get covered by insurance, but if a patient just can't tolerate any of the other treatment options that I explained, then this is a good one. So basically, a acid or product is put on the skin and then neutralized shortly thereafter to create basically a peeling effect. The peel doesn't start immediately. For example, if a patient has the peel applied on a Wednesday, they're going to end up doing most of their peeling over the weekend, Saturday and Sunday, and then smoother skin the following week. Almost universally, you're going to have to do multiple chemical peels to get all the AKs. And this is not something that would be used for particularly thick or hypertrophic AKs. But it is something that we do sometimes on the scalp because it can be really effective there. Okay, so moving on to skin cancer. Basal cell carcinoma is the most common form. If you have the diagnosis of basal cell, it is not a scary diagnosis. The actual death rate for basal cell is 0.01%. In the 21 years that I've been practicing, I've never heard of anyone passing away from a basal cell. It's a pretty good diagnosis. If you're going to have to get skin cancer, this is the one you want to get. So there are various types of basal cells, and generally depending on their thickness is how we treat them. Very, very common form. I wouldn't say number 1, but it's definitely common for the superficial type of basal cell is called curettage and electrodesiccation. We call it C&E for short, or C&E times 3. Times 3 is because we do 3 passes. So in this picture, you can see a curette. That is a scraping tool that's used to scrape the tumor off. The patient, this is done in a regular dermatology office setting. Local anesthetic is used. The patient can drive themselves to and from this appointment without any difficulty. They don't have to have anyone to help them. And we just locally anesthetize the area and then literally scrape off the tumor, cauterize it, scrape it, cauterize it, scrape it, cauterize it, right then and there, 3 passes, and it's done. The patient leaves with an area that looks and feels kind of like a scrape wound, and depending on where it is on the body, again, will dictate how quickly it will heal, usually within a week or 2. Excisional surgery is another extremely common treatment modality for basal cell. We'll use this for the little deeper forms, the nodular forms, micronodular, just because the scraping procedure will have a higher risk of recurrence. And so if this tumor is nodular or a combination of nodular and superficial, we're almost going to universally cut it out in this elliptical shape, which will leave the patient with a nice linear scar. So what to expect if this is your treatment option. It's also done in the dermatology office, something you can drive yourself to, eat and drink like normal. The area is locally anesthetized again, and the area is excised and closed with stitches. You'll have sutures in the area for anywhere from 5 to 14 days, again, depending on the location. Mohs micrographic surgery. This is a form of surgery developed by Frederick Mohs, Dr. Frederick Mohs. And it's a tissue-sparing surgery that we use for trickier basal cell lesions. There are a couple of forms that are slightly more aggressive, and if they're large tumors, if they're on the face, especially in a crease like the alar crease of the nose or behind the ear in the crease, it's very possible that with a simple excision visually, you are going to leave some tumor without realizing it. So we wouldn't do a simple excision in those cases. We would send it for Mohs micrographic surgery. So what happens in Mohs is if you're lucky enough and your dermatology office has a Mohs surgeon on staff, you will just go to your regular dermatology office. Otherwise, we will refer you out to a Mohs surgeon's office or clinic. And what happens is it's very similar to a regular excision initially, in that the area is anesthetized and locally, and then the visual area of tumor is removed with a regular excision, and the patient, instead of instead of closing the wound, what we do is bandage the patient, and they wait in a special waiting room while the Mohs surgeon looks at the sections of skin that have been removed under the microscope to verify that all 4 quadrants of that tumor are totally gone. If there are positive margins in any of those quadrants, the surgeon will go back and simply take as little skin as possible, but enough to have clear margins in all 4 quadrants. So the main point of Mohs micrographic surgery is to spare as much tissue as possible with excision. So as you can see in this picture, it's a temple. We want to get the best cosmetic result as well. Mohs is very frequently used for that. If a tumor is 1 centimeter or larger and on the face, or sometimes about that size and on the shin, and you'll have a trickier closure, we will frequently also send that to a Mohs surgeon. Radiation therapy is a far less common option, but it is an option for treating basal cells. The scarring potential is far more. Recurrence risk, it can be higher, and this isn't something that we would generally use on the face, even though that's the picture I chose. This is more often used for the patient that for whatever reason can't tolerate or does not want to have surgery, wouldn't be a candidate for surgery for whatever particular reason, but I put it in there because sometimes it is used. Even less frequent is our topical and oral medications for basal cell. We do use the topical cream frequently for the very superficial basal cells. That's a nice option to have, especially if it's on the face and you don't want to have further scarring by surgery. If it's a superficial spreading basal cell, then a cream called imiquimod can be used. Depending on your dermatologist's preference, it's applied multiple times a week. You get some days off because it does cause significant inflammation, very similar to the precancerous treatment. It's multiple weeks of looking very red, crusty, and scabby, but eventually the tumor will just regress and disappear. We do know this treatment has been around for a couple of decades, and we do know that it's very successful, but long term, we don't know the cure rates. They appear to be extremely good, however. Then there are also oral medications for severe basal cell situations, which are incredibly rare, and it's not something that I prescribe. Second most common form of skin cancer is squamous cell carcinoma. This is a little bit more aggressive than basal cell and could potentially metastasize if ignored. They are slow growing though, and generally very curable. Again, if the squamous cell carcinoma is superficial, curettage and electrodesiccation can be used depending on the site of the tumor. Excisional surgery is probably the most common form of treatment for squamous cell carcinoma. Again, you would use excisional surgery in a simple area, like the back of the arm, the leg, and that would be done just with local anesthesia in the dermatology office, or of course, Mohs micrographic surgery for the trickier locations and larger tumors. Radiation therapy, also an option for squamous cell. Again, this is most often used for the patients that for whatever reason cannot or will not tolerate surgery. Topical medications, less commonly used in squamous cell unless, again, it is the very superficial type called squamous cell carcinoma in situ. That is one tumor that we can use the cream alone in, and it works very well. But the only reason we would use the cream in a more aggressive form of squamous cell tumor is if it is a particularly large tumor. For example, if you had a big squamous cell on a patient's back, maybe 6, 7, 8 centimeters in diameter, that's just not going to be an option for excision. It's simply too large without a skin graft. So we will sometimes use these creams to try to shrink the tumor as much as possible prior to surgical excision to make sure that we get it all, but also make sure that we take out as little skin as possible for scarring and recurrence potential. Finally, melanoma, the big bad skin cancer. This is the one that is most deadly and the one that we really want to try to identify early with preventative skin exams. If you're diagnosed with melanoma, treatment will primarily depend on the depth of the tumor. So if your tumor is less than 1 millimeter in depth, it is most likely going to be removed with a plain old ordinary excision in your dermatologist's office, or perhaps Mohs if the location is warranting the Mohs surgery instead. And the depth of the melanoma will also dictate how much skin is taken around it for a margin, but generally it's going to be about 1 centimeter on each side, so they can be fairly substantial in size. If a melanoma is deeper than 1 millimeter, then you will be referred to a general surgeon for the excision with extra biopsy of lymph nodes. And we call that a sentinel node biopsy. And that is to see if it has, in fact, spread into the lymph nodes. We would refer the patient to a general surgeon, again, who will meet with the patient initially. If you are referred to a general surgeon, they will talk to you and discuss exactly what kind of anesthesia would be more appropriate for your situation, how big the excision is going to be, and the procedure in general, which lymph nodes will be biopsied, and how that all works. For example, if your melanoma is on the left shoulder, the lymph nodes that are going to be biopsied are going to be the closest to that area. So that would be your left armpit or left axilla for the lymph node biopsy. Again, that's done at the general surgeon's office, and then the patient is referred back to dermatology for further evaluation and follow-up. If a melanoma is particularly deep, concerning for any reason, we will send the patient to oncology as well for evaluation as to whether or not treatment with immunotherapy, chemotherapy, radiation, or now there's some oral medications that can be used for advanced melanomas. This is again done through the oncology office, which would partner with the dermatologist and basically be a team for taking care of the patient from then on. All right, you've gotten your tumor removed, you've had your surgery, you've gotten through that. What now? What about after treatment? It's really important to know that full skin exams are the most important way to diagnose these lesions early. And remember, the earlier we find them, the better. So when a patient has a history of a non-melanoma skin cancer, that is, for example, squamous cell or basal cell, or if they have actinic keratoses or precancerous lesions, our office policy is generally to see that patient every 6 months, a couple times a year for monitoring. If you have had the diagnosis of melanoma, we actually will see you a little bit more often. The first year, you have full skin exams every 3 months. The second year, it's every 6 months. And then after that, you go back to an annual full skin exam. Although most often in our clinic, we simply continue to do the 6-month exams because more often than not, a patient will develop a new lesion. Not necessarily a melanoma, but very frequently a little precancerous lesion. And again, we want to just catch everything as early as possible. So expect to have more frequent skin exams, anywhere from every 3 months to every 6 months to every year. Sun protection, sun avoidance. Of course, we emphasize sunscreen, 15 in the winter and 30 plus in the summer. Sun protection with clothing, hats, anything you can do is helpful. We don't expect you to live under a rock, but just be aware. And then if appropriate, supplementation with nicotinamide can protect a patient from free radicals believed to help prevent further skin cancer development. But this is not something that should just be assumed is safe. One should speak to their primary care doctor first to make sure that it's appropriate in their particular situation. Besides your dermatologist's office, there are loads of patient support resources. These are just 3 of my favorites. The Robin's Nest program from the Skin Cancer Foundation. www.thisislivingwithcancer.com. You can choose your cancer by type, and they have skin cancer in particular. And then www.skincancer.org. Very good, legitimate information to find on the internet. So you can find the right answers at these sites. Most important, and what you must not forget, is how important the full body skin exam is and the relationship that you develop with your dermatology provider. You should be very comfortable with them, be able to discuss any changes with your skin, any things that seem different, and just be aware. Thank you very much for your time. I hope you've learned something about skin cancer and possibly feel more comfortable about your potential treatment. Have a lovely day.